Hello, I'm Dr. Son Young-hui from Ijon Dental Office. This is the second lecture on medications. We frequently prescribe analgesics and anti-inflammatory medications. It requires more cautions when we prescribe them. I will explain the reasons why. We are dealing with analgesics and anti-inflammatory drugs. Usually we call them NSAIDs. As you know, it stands for non-steroidal anti-inflammatory drugs. They are all the drugs, anti-inflammatory drugs, except opioid analgesics and steroidal drugs. It started with aspirin, acetyl salicylic acid, ASA in short. Therefore, NSAID is also called aspirin-like drugs. There are many different types of NSAIDs. There are more than one kind of NSAID. Let's look at each type. Salicylates are the classic NSAIDs, such as ASA and salicylate. These are the classic NSAIDs. We know them as aspirin. Actually, it is from Bayer. There are many different types of aspirin. It has been used for a long time, and it is a very safe drug. However, we need to think about this aspect of aspirin. It lowers the rate of toxemia of pregnancy. So this is used by pregnant women a lot. It lowers the rate of toxemia of pregnancy and enhances the chance of pregnancy. So it used to be prescribed a lot to pregnant women, but it is found that cerebral palsy infant birth rate increases 2.5 times. So these days it is prescribed in a limited fashion, 80 to 100 milligrams once a day, except third trimester. So that's how aspirin is prescribed to pregnant women. So we need to be aware aspirin is used by a pregnant woman, so we need to find it out, identify the fact before prescribing the drug. Second, propionic acid, known as Advil, ibuprofen. Advil and Brufen are ibuprofen. Ibuprofen is the same as ibuprofen, except all R chains are removed and dextrose chains remain. Naproxen, phenoprofen, ketoprofen, dexketoprofen, flurbiprofen, all the way to loxoprofen. These are all propionic acid type NSAIDs. There are pills and there are also patches that use the drugs. So these are propionic acid NSAIDs. Next, acetic acid NSAIDs. The classic one is indomethacin, and also widely used are ketorolac, diclofenac, aceclofenac. These are very widely used NSAIDs. Next, oxychem. Piroxicam is the most frequently used one, so it includes piroxicam, meloxicam, and others. Next, phenamate. Pontal is the representative one. Phenamate NSAIDs. Next, most advanced NSAID is coxib, celecoxib, rofecoxib. These are coxib NSAIDs. These have resolved side effects of conventional NSAIDs, so these can be used for a very long period of time. So it's more expensive. And there are etc., including others. So all these are NSAIDs. You already know about mechanism of action of NSAIDs, so I will not go over that. Its mechanism is on the basis of their inhibition of the enzymes that synthesize prostaglandins. With arachidonic acid, there are varied mechanisms. Some are related to vasodilation or inhibition of platelet aggregation or bronchodilation. On the thromboxane side, vasoconstriction or platelet aggregation. And if you go to E2 or prostaglandin, three types of effects are achieved. As indicated here, simply put, NSAID is effective by inhibiting physiological activation, which involves prostaglandin. The processes influenced by NSAIDs, there are many. You don't need to know all about them, but you need to remember this. COX-1 and COX-2 are inhibited by NSAIDs. COX-1 is different from COX-2. COX-1 is constantly in the body for physiologic function. And COX-2, cyclooxygenase 2, is expressed only after inflammation occurs. Actually, what we want is to inhibit COX-2 only, but all NSAIDs are inhibiting COX-1, leading to side effects. Each NSAID has different degrees of inhibiting COX-1 or COX-2. In this order, indomethacin, aspirin, inhibit COX-1 more, leading to more side effects, followed by piroxicam, ibuprofen, diclofenac, meloxicam, and celecoxib. The later ones inhibit COX-2 more. There are four effects of NSAIDs: anti-inflammatory effect, analgesic effect, antipyretic effect, and antiplatelet effect. I believe you already know about this. So all of these can be achieved by inhibiting COX-2. Adverse drug reactions of NSAIDs. There are so many. GI problems, hepatic, renal, hematologic, cutaneous, respiratory, and CNS side effects or adverse drug reactions. All of these are caused by inhibiting COX-1. The most troublesome one is related to GI ADRs, indigestion, GI reflux, GI hemorrhage, perforation, or peptic ulcer. So there are so many things we need to be careful when taking NSAIDs or when prescribing them. There are NSAIDs that need to be taken with food or antacid. Drugs with less GI problem should be taken 30 minutes prior to or 2 hours after a meal. Alcohol should not be used while on medication. Duplicate NSAIDs should not be used together. Photosensitivity may occur. For diarrhea because of mefenamic acid, you should consult with the internal medicine doctor. An antidiarrheal should not be used. NSAID hypersensitivity should be checked. For treating a patient, NSAID use should be checked with the patient. Orthopedic department use NSAIDs a lot, and the duplicate use is screened by DUR. Often we cannot prescribe the drug that we want. Drug interaction of NSAIDs, most of them are in category B or C, but it will be under D when used for a long time. They lower the effect of antihypertensives. Cimetidine increases the activity of piroxicam. They increase the blood concentration of digoxin. Aspirin should not be prescribed for analgesic purpose because of thrombus. Many hypertensive patients are on aspirin protect. Can we prescribe NSAIDs for such patients? That's a question. Yes, we can do that. How can we do it? Aspirin should be taken first, and NSAIDs should be taken 30 minutes later. Or aspirin can be taken 8 hours after taking NSAID, but aspirin Protect is taken together with antihypertensive before a meal. So the second description is not feasible. So NSAID should be taken 30 minutes after aspirin. Thus, NSAID can be prescribed for those on aspirin Protect. It is better if it is of different base like acetaminophen or tramadol. Of course, in this case, anti-inflammatory effect cannot be expected, but if the purpose of using the drug is to control pain, NSAID can be prescribed. So this is the general description of NSAID. Let's look at frequently used NSAID. First, Ponto, category B. It can change to category D when used for a long period of time. So each NSAID has different analgesic or anti-inflammatory effect. Ponto doesn't really have anti-inflammatory effect. To reduce GI irritation, it should be taken with 200 cc or more water. A patient should not lie for 30 minutes after taking the drug. It can cause drowsiness, so there's no need to prescribe this now. Per oral administration, ibuprofen is the most often used one. It is in category B, but can become category D when used for a long time, and the Advil is the representative one. The daily dose can increase to 3,200 milligrams. It is a pretty effective drug, but the shortcoming is a short half-life. To control pain, you need to take it 4 times a day, every 4 to 6 hours. The advantage is it is safe for children, so it is available in syrup. This is the NSAID I like very much. Ibuprofen is found to prevent Parkinsonism in a recent study. Next, diclofenac sodium, which is most widely used. It is not prescribed in a dental clinic very much, but including the medical field, it makes up 1/3 of all prescriptions. There are injections in ER form. ER means extended release. So the English letters ER is attached to the name. Diclofenac has superb analgesic effect, but it is reported that it increases the risk of cardiovascular disease. So we need to be careful in prescribing the drug. When the patient is under severe pain, it is okay to prescribe it, but I prefer to use aceclofenac, which is safer because it has stronger COX-2 selectiveness, so it leads to less side effects of GI. Both diclofenac and aceclofenac are used for arthrosynovitis, for inflammation in joints. Next, loxaprofen. Now, it is in the mainstream in terms of safety and efficacy. It is in the middle. Loxaprofen is in the middle of the spectrum. A single dose is 60 milligrams and 3 times a day. It should not be used together with ketorolac. Ketorolac is not used often these days, but sometimes we have to use it. Next, the piroxicam. It is in FDA category C, but it will be under D if used for a long time. It has good efficacy, and it has very strong anti-inflammatory efficacy. That is the difference from other drugs, and GI and cutaneous adverse drug reactions are reported, and it should be used when other drugs don't work. It used to be prescribed 40 milligrams a day, but it is reduced to 20 milligrams per day. Therefore, my criteria of using NSAID is that we don't need to use drugs with a lot of ADRs. Terracin is known for ketorolac drug. This is to control pain. It has almost no anti-inflammatory effect. It is just to control pain. Its advantage is it has the strongest pain control effect except opioid analgesics. It has the most drugs not to be used together. It should not be used for 16-year-olds or younger or for more than 7 days. So I do not recommend this to be used. Next, this is not NSAID. This is a pain control agent, tramadol and Ultracet. Tramadol is not for fever reducing or anti-inflammatory effect. It is a weak opioid. It is only for pain control. It works on CNS. It has a similar mechanism of action to opioid, but it is not opioid. There will be withdrawal symptoms. Tramadol is for pain control, so when patient is under pain, this is used together with other drug. Ultracet is made by Janssen, which made Tylenol. Basically, Ultracet is a combination of acetaminophen and tramadol. So it has a very strong pain control effect. It controls pain very well, but no anti-inflammatory effect at all. It is used quite a lot by orthopedic department for sprain. As it has a strong pain control effect, it has strong adverse drug reactions. Slightly more adverse reactions in young people. The common adverse reaction includes nausea and vomiting. So this should be prescribed when absolutely necessary. Acetaminophen, Tylenol, which is used most widely. If this is prescribed to people of 60 years old or older, DUR will pop up and we need to change the medication. Tylenol patent is expired, so there are many generic drugs. There is no anti-inflammatory action. The side effect is liver toxicity only when used excessively. For adults, the maximum allowed tolerance is 3 grams a day. There are so many varieties. Tylenol for children, women's, Tylenol ER or cold. There are about 2,300 local generics. Almost all general cold medicines sold in Korea are based on acetaminophen. Next, enzyme anti-inflammatories. Serratiopeptidase used to be used quite a lot, but now streptokinase is used. This is reducing swelling. So after surgery, if a patient is expected to swell a lot, this can be a good choice. So these are the NSAIDs used and prescribed a lot in a dental clinic, and also pain control drugs. Actually, when do we prescribe NSAIDs? To control inflammation? I don't think so. Mostly, they are used to manage patients' pain. Then, what NSAIDs are prescribed by dentists a lot? There is no such study results in Korea, so this is from Turkey. It is different from Korea. There, naproxen is used the most. Dentists did not prescribe selective COX-2 inhibitors like celecoxib or valdecoxib, so these are hardly prescribed. Weak opioids as well. So that's what is found here. And it is also found that 2 or more NSAIDs are used or prescribed together, which should not be the case. NSAIDs have the effect for fever, pain, and inflammation with toxic side effects. Pain reduction doesn't go up with the increased dose. This is called ceiling effect. Doubling the dose doesn't increase the effect twofold. So you need to adhere to the dosage. It is not desirable to prescribe a combination of the same NSAIDs. If they have different mechanism between the NSAIDs, they can be prescribed together. For example, ibuprofen or loxaprofen. They do not reduce the pain further. Then, for monotherapy, what medications should be prescribed? Pain control is more important than inflammation control in my experience. So I don't think my own opinion would be objective. So let me cite Oxford League table of analgesic efficacy. Required analgesic amount to control postoperative pain of moderate or higher severity. In terms of NNT, number needed to treat. The number of administrations needed to reduce the pain 50% or more for 4 to 6 hours. Smaller the number, the stronger the analgesic effect. The result is as expected. Etoricoxib, celecoxib has very small NNT, so they are taken once a day. So that's the point. And celecoxib cannot be routinely prescribed. The reimbursement is continuously reduced. What does this table mean? This is the NNT. So looking at this, what we can tell is that if you look at ibuprofen, 200 milligrams versus 400 milligrams, between them the NNT difference is 0.2. So there is no need to take twice the amount. Also, naproxen, 200 versus 500 milligrams, the NNT difference is only 0.7. So the higher amount doesn't mean better efficacy. Second, paracetamol, which is acetaminophen. When 600 mg is taken, NNT is 4.6. Tramadol, 100 mg, NNT is 4.8. So NNT levels are like this. If two of them are taken, paracetamol, Tylenol 650, and Tramadol 75 are taken together, the NNT drastically is reduced to 2.6. Taking two different drugs with a different basis would have very good efficacy in reducing pain. So when an NSAID is taken and the pain persists, rather than giving one more of the same drug, we need to prescribe an NSAID with a different base like acetaminophen or tramadol. How to prescribe them? According to the paper here, if possible, they need to be taken by mouth because patients can control the amount of drug that they take, and they need to be taken by clock and by letter. I will explain that later. And they should be taken by individual. Change of pain and the side effects need to be evaluated to control the drugs accordingly. We already know aspirin causes bleeding. Aspirin is not good in controlling pain because it causes thrombus at the analgesic dose. Ibuprofen is safe, but it should be taken frequently because of short half-life. To reduce the number of administrations, naproxen with long half-life or coxib, like celecoxib, need to be administered. Aceclofenac and diclofenac are more COX-2 selective. It is recommended because of good analgesic effect with reduced GI side effect. Ketorolac has very strong analgesic effect, however, it has the highest bleeding tendency. As you can see, ketorolac 10 milligrams side effect is much bigger than those on the right. So they say it's risky if it is taken more than 5 days. NSAID can cause GI bleeding like this. It is more severe with the ketorolac and is reduced in the order of naproxen, diclofenac, and ibuprofen. To prevent this, the usual digestant or GI agents like mosapride, aclatonium, or amagate would not work. Misoprostol H2 antihistamine, cimetidine, ranitidine, and PPI proton pump inhibitor inhibits gastric acid secretion. So these need to be administered, or acetaminophen or tramadol, the alternative drugs need to be administered. NSAID shows bleeding tendency, so if you see GI adverse effects, you need to respond to it quickly. How can we prescribe that? By letter, WHO talks about analgesic letter for adults, generally for cancer pain. This can be applied to post-op pain as well. Non-opioid is the standard. That means NSAID. Acetaminophen is included in non-opioid for mild pain. If that doesn't resolve the pain, weak opioids can be added, codeine, tramadol, or low-dose morphine. If that doesn't resolve the pain problem, strong opioids can be used, morphine, fentanyl. And we cannot go to that level. Usually, we can go up to weak opioids. To control pain, we can start with NSAID or acetaminophen. However, if the pain doesn't go away, we can add the weak opioids. We need to consider carefully when we look at this table. There's one thing to consider. There are many adjuvants like antidepressant and anticonvulsant, but that's not realistic. Opioids and non-opioids, it can be combined and it has very good efficacy. But if the drugs are of the same class, they should not be used together. Second, time doses based on a drug half-life. The administration should be determined based on the efficacy, and we should not wait for pain to recur. So the drugs should be taken before pain recurs. So we need to tell the patient to keep time in taking the drugs. This is for your information. In 2013, Moore wrote this paper. This is about what need to be used for drugs for acute pain management after third molar extractions. This is the conclusion. Two need to be taken together. Here they use ibuprofen and acetaminophen, which are widely available. When these two are used, the best NNT and analgesic effect were achieved. So after extraction, when moderate or more severe pain is expected, ibuprofen needs to be taken together with acetaminophen. The paper says it achieved a very good result. For mild pain, ibuprofen needs to be taken every 4 to 6 hours. For mild and moderate pain, ibuprofen needs to be taken every 6 hours for the first 24 hours, and after that, when necessary, ibuprofen can be taken every 4 to 6 hours. For moderate and severe pain, acetaminophen can be added. For severe pain, ibuprofen, acetaminophen, and hydrocodone can be used. Hopefully, we don't want to go that far, so the paper said ibuprofen, acetaminophen with the different classes can be used together for better analgesic effect. So we have talked about NSAIDs NSAIDs is effective. It has very good analgesic effect, but it has a lot of adverse reactions. If patients can overcome that, it would be okay, but I have experienced a couple of cases where it was very difficult. So I talked about the standard of using NSAIDs. I hope this has been helpful. Thank you for your attention.